Hi, I'm Michelle O'Donoghue. I'm going to be reviewing the management of patients with ST elevation myocardial infarction. These are my disclosures. Overall, there have been favorable trends in the number of hospitalizations for acute coronary syndromes, myocardial infarctions, and unstable angina cases over the past 10 to 15 years. The decline in acute coronary syndrome cases has been accompanied by a decline in myocardial infarction cases. And when we drill down and look at the age and sex-adjusted incidence rates of acute MI between 1999 and 2008, we see that there has been a progressive decline in the number of ST elevation MI cases. So all of this is leading off with some good news. Also good news is that there has been a progressive decline over the past couple of decades in the number of deaths related to ST elevation MI. This is mortality rates that you're looking at on this graph, both in hospital as well as through to 30 days and 1 year. You can see that over time, since 1996, there's been a progressive stepwise decline in mortality in patients with ST elevation MI. So one of the key concepts for management of patients of ST elevation MI is the idea that time is muscle, that the longer it takes to reperfuse a patient, the larger there may be the zone of necrosis. And in turn, we know that a larger zone of necrosis is associated with worse outcomes. So a lot of emphasis over the past few years has been placed on early recognition by the patient and early initiation of treatment by EMS, getting an early ECG during transport, as well as initiating some evidence-based therapies as soon as possible, even within the ambulance within certain circumstances. Also, we'll discuss a little bit more about different modes of reperfusion and optimal strategies for which hospital to bring a patient to if an ST elevation MI is confirmed. This slide is showing the relationship between the presentation delay and outcomes, both for patients with primary PCI as well as those with, who undergo fibrinolysis on the right-hand side. The longer the time from symptom onset to presentation for primary angioplasty, there's a progressive increase in 6-month mortality. A similar trend is seen also for patients who undergo fibrinolysis. The longer the time from symptom onset to presentation, the worse the outcomes. This is a very consistent theme. This graph is showing a similar concept, just plotted differently. On the y-axis, you have mortality reduction. So you can see that the mortality reduction is minimized, hence there's higher mortality, the longer the time from symptom onset to reperfusion. What's interesting about the shape of this graph is you can see that between 1 to 3 hours, that is really the critical time window during which we can make the most difference in terms of improving a patient's outcome if they're hospitalized with STEMI. As you're aware, there are 2 basic reperfusion strategies for patients with ST elevation MI. The first and preferred strategy that we'll be discussing first of all will be primary PCI. And the second strategy is fibrinolysis. Although primary PCI is generally considered to be the preferred mode of reperfusion, nonetheless, fibrinolysis remains the #1 form of reperfusion worldwide, given that a lot of patients do not have ready access to a hospital that has a 24-hour cath lab available. So the first step for considering who is appropriate for reperfusion therapy if a patient presents to a hospital with ST elevation MI, the first question is do you need to have this patient undergo immediate reperfusion therapy? For instance, really is the time is muscle concept applying here? So we should be considering immediate reperfusion therapy in patients in whom they are within 12 hours of symptom onset. For those who are beyond 12 hours from symptom onset, so between 12 to 24 hours after symptom onset, if they're continuing to have ECG evidence of ongoing ischemia, or if they're continuing to have ongoing clinical symptoms. So for instance, if they're having continued chest pain or any clinical instability. In those situations, we should be considering immediate reperfusion. As mentioned on the prior slide, primary PCI, including transfer to a PCI-capable hospital, is generally considered to be the preferred reperfusion strategy. This is based on data that have compared in a randomized manner outcomes for patients who undergo primary PCI versus fibrinolysis. As you can see on this slide, the patients treated with fibrinolysis are highlighted in pink, and those undergoing primary PCI are highlighted in blue. Across the board, you can see the primary PCI led to a lower risk of death, reinfarction, stroke, as well as a lower rate of intracranial hemorrhage. For this reason, primary PCI remains the preferred mode of reperfusion. But what if you don't have access to a 24-hour cath lab? The patient might be transported to a hospital in which that's not going to be possible. This slide is reflecting the decision-making that goes into whether or not it is preferred, if a patient arrives at a non-PCI capable hospital, whether to transfer them to a PCI capable hospital, or whether or not to just go ahead and reperfuse them with fibrinolysis, assuming that they're a suitable candidate. You can see that the tipping point in the decision-making seems to be about 120 minutes in terms of whether or not it is considered to be worthwhile or beneficial to still transfer the patient to a PCI capable hospital. Beyond the 120-minute mark, it appears that any benefit that one would have had from primary PCI is offset by the delay, and therefore the larger territory of potential necrosis. So in those situations, fibrinolysis may be preferred. As such, these are the official ACC-AHA guidelines at this time in the management of ST elevation MI in terms of decisions about reperfusion therapy and timed treatment goals. The first one is that reperfusion therapy should be administered to all eligible patients with STEMI with symptom onset within the prior 12 hours, that primary PCI is the recommended method of reperfusion when it can be performed in a timely fashion by experienced operators, and EMS transport directly to a PCI-capable hospital for primary PCI is the recommended triage strategy for patients with ST elevation MI with an ideal time from first medical contact to device system goal of 90 minutes or less. So in other words, when the patient obtains first medical contact, if they're being transported to a PCI-capable hospital, we are hoping that the door-to-balloon time can be maintained under 90 minutes. This next slide is addressing questions about whether or not to transfer a patient. Immediate transfer to a PCI-capable hospital for primary PCI is the recommended triage strategy for patients with STEMI who initially arrive at or are transported to a non-PCI-capable hospital with an FMC to device system goal of 120 minutes or less. If it exceeds 120 minutes and the patient is at a non-PCI-capable hospital, in those situations, fibrinolytic therapy should be considered, assuming that the patient is a suitable candidate. This slide is illustrating the same concepts, but just in a different type of figure, just to reinforce these points. So if a patient presents to a PCI-capable hospital, they should be sent to the cath lab for primary PCI with an ideal FMC, so first medical contact to device time of less than 90 minutes. In contrast, if you have a patient who is being seen at a non-PCI-capable hospital, they should be transferred for primary PCI if we believe that the FMC to device time will be less than 120 minutes, or if it's expected to be beyond that time frame, then the patient should be initiated on fibrinolytic therapy as appropriate, or possibly transferred to another hospital for PCI if inappropriate. Next, we'll be discussing the data to support different types of anticoagulant decisions to support primary PCI. Overall, the majority of hospitals at this time use unfractionated heparin. Nonetheless, there is continued interest in the use of bivalirudin as an anticoagulant in support of patients undergoing primary PCI in the setting of an ST elevation MI. Some of this enthusiasm stemmed from the Horizons AMI trial that showed not just a reduction in cardiovascular events, but a reduction in mortality for patients who were treated with bivalirudin alone when compared to the combination of heparin with a glycoprotein 2B3A inhibitor. This was a 31% reduction in all-cause death through 12 months. Meta-analyses have been conducted looking at all published trials of bivalirudin in patients undergoing PCI. This is not just patients with STEMI, but across the board. And when you just compare a bivalirudin-based regimen to a heparin-based regimen, it becomes somewhat less clear that head-to-head one anticoagulant is superior to the other. And to that end, there have been concerns raised that when you compare bivalirudin to a heparin-based regimen, that there may be a higher rate of acute stent thrombosis really early on for patients who were STEMI patients undergoing PCI with a bivalirudin-based regimen. Overall, though, it does appear that a combination of bivalirudin with a provisional glycoprotein 2b3a inhibitor does reduce the risk of bleeding when compared to heparin and a planned glycoprotein 2b3a inhibitor. Again, it remains unclear whether or not this difference is largely just driven by the addition of a glycoprotein 2b3a inhibitor as opposed to fundamental differences between bivalirudin and unfractionated heparin in and of themselves. There's also some data that has looked at the use of fondaparinux. One takeaway point is that fondaparinux, although it may have a role in the medical management of acute coronary syndromes, it does not appear appropriate for patients who are going to the cath lab. This is because there's a higher instance of catheter thrombosis in patients undergoing PCI, and hence fondaparinux is not recommended for patients undergoing primary PCI in the setting of STEMI. In summary, the guidelines have said that it is reasonable to use either unfractionated heparin with additional boluses administered as needed to maintain therapeutic activated clotting times, and also with or without the addition of a glycoprotein 2b3a receptor antagonist, or bivalirudin with or without the prior treatment of unfractionated heparin. So basically either or, you can use unfractionated heparin or bivalirudin. However, there's a class 3 indication saying that fondaparinux should not be used as a sole anticoagulant to support primary PCI because of the risk of catheter thrombosis. Next, we'll be delving into antiplatelet therapy in the setting of ST elevation MI. This is a slide just to remind you about the different pathways leading to platelet activation. We have aspirin that targets the COX enzyme, leading to a decrease in production of thromboxane A2 and a decrease in platelet activation via that pathway. Many of the drugs that we have in our arsenal target the P2Y12 receptor, including clopidogrel, prasugrel, ticagrelor, and IV cangrelor that we'll discuss in more detail. There's also a drug called Vorpaxar that activates that blocks activation of platelets via the PAR1 receptor. We will not be discussing that in greater depth in the context of ST elevation MI patients. As already alluded to, there are also glycoprotein 2b3a receptor blockers or antagonists that target platelets that have already been activated, since the final common pathway of platelet activation is expression of the glycoprotein 2b3a receptor. So those blockers help to prevent cross-linking of the platelets. Aspirin has long been one of the mainstays of management of an acute ST elevation MI. This started in even before 1988, but supported by data in the ISIS-2 trial that was published in 1988 that demonstrated in a 2x2 factorial design that streptokinase was beneficial when compared to placebo for patients with ST elevation MI, but also aspirin on its own appeared to offer as much benefit as streptokinase in this same patient population, and the combination of both streptokinase and aspirin offered additive benefit. Most of the data that we have to support the use of clopidogrel in the setting of ST elevation MI is actually inferred from prior studies of clopidogrel in either UA and STEMI or in the setting of PCI. Just to remind you that CURE studied the use of clopidogrel, the P2Y12 receptor blocker, on a background of aspirin therapy in patients with UA and STEMI. Largely, though, this was a conservatively managed patient population, but demonstrated that clopidogrel reduced the risk of cardiovascular death, MI, or stroke by 20%. We believe that the benefit might be even greater in patients who are undergoing stenting. However, one of the limitations that we know about clopidogrel is that, one, it's very slow in onset, which is not ideal for patients in the setting of ST elevation MI. And there also exists significant interpatient variability in response to clopidogrel. In particular, it's been suggested that approximately 1/3 of patients, when you measure their platelet inhibition in a test tube, do not appear to have adequate inhibition of platelet aggregation following a 300 milligram loading dose of clopidogrel. So prasugrel is a newer drug that also targets the P2Y12 receptor like clopidogrel, and has been demonstrated to be more potent and have less interpatient variability than clopidogrel. Looking at this slide, it's showing inhibition of platelet aggregation on the y-axis. You can see with clopidogrel that there's pretty wide interpatient variability. When the same group of patients is crossed over to prasugrel, you can see that there's diminished interpatient variability, but also the lines tend to go upwards, suggesting higher potency in regards to greater inhibition of platelet aggregation. The TRITON-TIMI 38 trial studied more than 13,000 patients with ACS, both STEMI and non-ST elevation ACS undergoing PCI, and demonstrated that on a background of aspirin therapy, prasugrel significantly reduces the risk of cardiovascular death, MI, or stroke by 19%, translating into a number needed to treat of 46. When one looks specifically at the results within the STEMI cohort, this was a population of 3,534 patients. The benefit appeared to be perhaps even greater. The early on benefit was apparent in terms of reducing peri-procedural events, and also over the long term, a 21% reduction in cardiovascular events. We'll discuss the excess in bleeding with prasugrel in upcoming slides, but in the STEMI cohort, the bleeding with prasugrel only slightly exceeded that with clopidogrel. As mentioned, though, for the trial overall, prasugrel, as it is a more potent antiplatelet drug, does increase the risk of bleeding as compared to clopidogrel. This includes TIMI major bleeds, as well as life-threatening and fatal bleeds. It has not been shown, though, to increase the risk of intracranial hemorrhage. When one looks at patient groups who shouldn't get prasugrel because they don't appear to benefit and there may be a safety concern, patients with a prior history of stroke or TIA are patients who are not appropriate for prasugrel. And with patients who are older, over the age of 75, or weight less than 60 kilograms, there should perhaps be consideration as to whether a lower dose of prasugrel or perhaps an alternate agent should be used. Ticagrelor is the next P2Y12 antagonist that we'll be discussing. Unlike prasugrel and clopidogrel, it is a reversible drug and does not require metabolic activation. Similar to prasugrel, it does have rapid onset of its inhibitory effect, and it's also more potent. As mentioned, it's reversibly bound. The effects persist, though, over several days. Looking at the results of Plato, this was a trial, the phase 3 trial of ticagrelor that enrolled more than 18,000 patients with an acute coronary syndrome. Again, patients both with ST elevation MI and non-ST elevation ACS, regardless of whether or not they were undergoing PCI. Ticagrelor was shown to significantly reduce the risk of cardiovascular events, specifically cardiovascular death, MI, or stroke, by 16% when compared to clopidogrel on a background of aspirin. Some of the enthusiasm from the results of Plato and ticagrelor came as a result of the fact that there was also shown to be a mortality benefit with ticagrelor in secondary analyses. Ticagrelor significantly reduced the risk of cardiovascular death by 21%, in addition to the benefits for reducing myocardial infarction. Within the ST elevation acute coronary syndrome cohort, the benefit of ticagrelor appeared to be consistent. and was basically overall consistent with the Plato study results. Ticagrelor, though, because it is a more potent drug, does appear to increase the risk of non-cabbage-related bleeding, as was seen with prasugrel. However, perhaps because of its reversible nature, that does not appear to be true for cabbage-related bleeding. So when they looked specifically at cabbage-related bleeding, ticagrelor did not increase the risk of those particular types of bleeds, and if anything, trended towards being numerically smaller. One thing to be aware of is that ticagrelor does appear to have side effects that are not seen with prasugrel or with clopidogrel. Specifically, ventricular pauses have been observed. There's not an increased need for pacemakers and there's not an increased risk of syncopal episodes, but this is something that has been observed on telemetry. Similarly, there has been an increased reporting of dyspnea associated with the use of ticagrelor, and this is something to be aware of for patients who you are treating with the drug. So the ACC-AHA guidelines in the setting of primary PCI for ST elevation MI indicate that a loading dose of a P2Y12 receptor inhibitor should be given as early as possible or at the time of primary PCI to patients with STEMI. The options include all three: clopidogrel 600 milligrams, prasugrel 60 milligrams, or ticagrelor 180 milligrams. The lower dose of aspirin is to be used longer term for maintenance therapy, although the higher dose of 325 should be used on the first day. It is recommended the P2Y12 inhibitor therapy be given for 1 year to patients with STEMI following placement of a bare metal stent or drug-eluting stent. And again, there are options for any of the three drugs, clopidogrel, prasugrel, or ticagrelor. A lower dose of aspirin, 81 milligrams, is advised really for all patients, but in particular for patients who are on ticagrelor. I had alluded to the use of glycoprotein 2B3A inhibitors. We won't discuss this in much detail, but can be used as an adjunct to unfractionated heparin therapy for patients undergoing primary PCI. Data throughout the years have demonstrated a clinical benefit for the use of 2B3A inhibitors, although many of these trials have not been reproduced more recently with some of the more potent P2Y12 drugs that are now available. The ACC-AHA guidelines still say that it is reasonable to start treatment with a 2B3A receptor antagonist at the time of primary PCI in selected patients who are receiving unfractionated heparin. You have the option of the three different agents. I'll touch briefly on the use of cangrelor, as some hospitals have begun to incorporate that into their arsenal of medications. Cangrelor is the only intravenous P2Y12 receptor blocker that is currently available. One of the advantages to cangrelor is that it has very fast onset and offset kinetics, which does make it conceptually appealing for an interventionalist who may not want to load the patient prior to PCI on an oral P2Y12 antagonist. In the Champion Phoenix trial, patients who had been randomized to cangrelor were then loaded with clopidogrel 600 milligrams at the end of the case, so following the infusion of cangrelor, or compared to patients receiving clopidogrel at the time of PCI. Overall, in Champion Phoenix, cangrelor significantly reduced the risk of cardiovascular events at 48 hours when compared to a strategy of just administering clopidogrel at the time of PCI. Again, as such, some hospitals have begun to incorporate cangrelor into the management of their patients with ST elevation MI who are undergoing primary PCI. I will just touch on a couple of additional considerations for patients who are undergoing primary PCI. Specifically, first, aspiration thrombectomy. Although there was interest and potential benefit suggested in some studies with a strategy of aspiration thrombectomy, overall now the weight of the data suggests that there is no benefit for this strategy and potentially an increased risk of stroke. As such, the ACC/AHA guidelines now say that routine aspiration thrombectomy before PCI is not useful. So that is now a Class 3 recommendation. There's also been interest in preventive PCI in the setting of ST elevation MI. Some studies have suggested that if you treat more than the culprit artery, so if you treat additional lesions that may be present in the setting of an ST elevation MI patient, that there may be incremental benefit in terms of reducing future risk of cardiovascular events as compared to treatment of just the infarct-related artery. These were all fairly small studies. PRAMI was 465 patients, culprit 296 patients that treated lesions either greater than 50% or greater than 70%, again, that were not in the culprit-related artery. As a consequence, there was a Class 2B indication that was entered into the ACC/AHA guidelines on the last go-around that said that one could consider treatment of the non-infarct artery in the setting of an ST elevation MI, either at the time of primary PCI or as a planned staged procedure prior to the patient being discharged from the hospital. However, just to note that since the publication of the ACC/AHA guidelines for STEMI, there has now been a new study presented, the culprit shock trial, that has indicated that PCI of the non-culprit artery is not recommended in patients who present with ST elevation MI complicated by shock. So we'll need to see whether or not this might be updated in the future version of the ACC/AHA guidelines, but is expected that that will probably be the case. So we discussed briefly reperfusion at a non-PCI capable hospital. Again, these are patients who are within 12 hours of symptom onset or 12 to 24 hours after symptom onset, only if they're continuing to have clinical symptoms or ECG evidence of ongoing ischemia. As you'll recall, 120 minutes is also the time frame during which you should be considering whether or not the patient should be transferred to a PCI-capable hospital. If it's going to take longer than 120 minutes, then fibrinolytic therapy should be considered in patients who do not have a contraindication. Listed at the bottom of the slide are the absolute and relative contraindications to fibrinolytic therapy. The ACC/AHA guidelines currently say that fibrinolytic therapy should be administered within patients who've had symptom onset within the past 12 hours, again, if PCI cannot be performed within 120 minutes of first medical contact. Similarly, it says that it can be administered within 12 to 24 hours of symptom onset in patients with ongoing symptoms and a large area of myocardium at risk, or patients with clinical instability. There have been two studies, a CLARITY study as well as the COMMIT study, that have looked at the addition of clopidogrel in patients undergoing fibrinolytic therapy. CLARITY patients were administered clopidogrel on a background, largely of aspirin, and demonstrated a reduction in cardiovascular events for patients treated with clopidogrel, as well as greater patency of the infarct-related artery. The COMMIT trial was a large study of more than 45,000 patients with an acute MI. Aspirin and fibrinolytic therapy was only administered in approximately half, so there were some patients who were being medically managed without other forms of acute reperfusion therapy, but demonstrated a 9% relative risk reduction for patients treated with clopidogrel at the time of lytic. Patients, the ACC/AHA guidelines now endorse the use of both aspirin in combination with clopidogrel, a loading dose for patients receiving fibrinolytic therapy. A loading dose should be used for patients less than 75 years of age. For those patients who are older than 75 years of age, the loading dose should be foregone, and you should just use the 75 milligram maintenance dose to patients who are receiving fibrinolytic therapy. Considering different anticoagulants that can support the use of fibrinolytic therapy in STEMI, the Extract TIMI 25 trial compared unfractionated heparin to enoxaparin in patients receiving fibrinolytic therapy and demonstrated a clinical benefit in the primary endpoint of death or non-fatal reinfarction at 30 days, as well as a reduction in the secondary endpoint as well, suggesting that low molecular weight heparin may be a reasonable option as an adjunct for patients receiving fibrinolytic therapy. As summarized previously, you have the options for unfractionated heparin, you have the options for enoxaparin, also fondaparinux. Since here we're talking about patients who are not going to the cath lab, it may be appropriate to use any of these three anticoagulants for patients who are going to be treated with fibrinolytic therapy. So what should one do after fibrinolysis? If it fails, so if there is evidence of persistent ST elevation, or if the patient is having ongoing symptoms, development of shock, or evidence of infarct-related artery reocclusion, that patient should be urgently taken for PCI. If it succeeds, then there are two considerations. One would be just non-invasive ischemia testing, like stress test at the non-PCI capable hospital, or preferably transfer of the patient within 3 to 24 hours for elective PCI. So in particular for higher risk patients, this strategy is recommended. The slide below is demonstrating a reduction in cardiovascular events for patients who were sent for routine early PCI after lytic therapy as compared to just standard treatment. So this is a slide, summary indications for transfer for angiography after fibrinolytic therapy. So it is recommended under the guidelines as part of an invasive strategy in stable patients with PCI between 3 to 24 hours after successful fibrinolysis. Again, if there are if there's any clinical instability or reason to believe that reperfusion was not successful, then the patient should be transferred immediately. There has been interest along the way in the concept of facilitated or pharmacoinvasive PCI. So basically when you have a patient coming to a non-PCI capable hospital, whether or not to start them on some form of pharmacologic therapy and transfer them immediately for angiography. So for instance, giving them fibrinolytic therapy and then urgently taking them for PCI. Different combinations have been studied, lytic alone, 2B3A inhibitor alone, or the combination of lytic and 2B3A inhibitor. Overall, there has not been any clear benefit demonstrated with any of these strategies. For that reason, the ACC/AHA guidelines say that use of a full-dose fibrinolytic followed by immediate PCI is not recommended. So you should be really waiting more than 3 hours before considering PCI in patients who have received fibrinolytic therapy unless there's an urgent indication. Rescue PCI, again, the concept of patients who receive lytic therapy but have not had complete resolution or have had less than 50% resolution of their ST segments at 90 minutes. Rescue PCI, as compared to just repeated thrombolysis or conservative therapy, has been shown to reduce the risk of cardiovascular events substantially. If a patient is beyond the typical window for reperfusion, so they have a late presentation from symptom onset in the setting of an ST elevation MI, much of the data that support the guideline strategy is from the OAT trial that suggested that a closed infarct-related artery should not be opened for patients who are beyond the acute phase of their ST elevation MI. To that end, the guidelines say that delayed PCI of a totally occluded infarct-related artery greater than 24 hours after an ST elevation MI in stable patients should not be pursued. We'll wrap up by going through additional routine medical therapies that are used in ST elevation MI. One question that remains debated is whether or not there may be potential harm from oxygen supplementation for patients who are not hypoxic. So if their oxygen saturation is greater than 94%. There have now been a couple of studies looking at this, suggesting potential harm. I'm showing here the results of one, the AVOID trial, suggesting that there may be a larger infarct for patients who receive oxygen if they're not hypoxic at the time of presentation. At this time, the guidelines have not weighed in on this issue. Beta blockers are routinely used for many patients with ST elevation MI. There's data dating back all the way to 1986. There's a study in ISIS-1 comparing IV followed by oral atenolol in 16,000 patients with suspected MI and demonstrating a significant reduction in cardiovascular events, including a 15% reduction in vascular death for patients treated with beta blocker as compared with placebo. When one looks across different trials, ISIS-1, COMMIT, Miami, overall there appears to be about a 17% reduction in reinfarction for patients receiving a beta blocker as compared with controls. The only caveat is that for patients who have any evidence of heart failure at the time of presentation, there does not appear to be any benefit and, in fact, potential harm for treating those patients with beta blocker. So if they have an elevated kilowatt class in the setting of presentation with an ST elevation MI, beta blockers should not be administered. As I just indicated, the guidelines support this recommendation, saying that oral beta blockers should be initiated in the first 24 hours in patients with STEMI who do not have any of the following: signs of heart failure, evidence of a low output state, increased risk for cardiogenic shock, or other contraindications to the use of oral beta blockers, for instance, a prolonged PR interval, second or third degree heart block, active asthma, or reactive airway disease. They can continue to be used throughout the hospitalization in patients who do not have a contraindication to their use. Next, we'll just touch on the data for ACE inhibitors in patients with an ST elevation MI. The SAVE trial randomized more than 2,000 patients with a post-MI LV ejection fraction less than 40% and randomized them to captopril or placebo, demonstrating a 19% reduction in mortality for patients who received an ACE inhibitor in that setting. Looking at all-cause mortality, we can see that there has been demonstrated with ACE inhibitors to be a significant reduction of 26% in subsequent all-cause mortality with the use of an ACE inhibitor in patients with either symptoms or signs of heart failure or reduced ejection fraction. For that reason, the ACC/AHA guidelines support the use of an ACE inhibitor within the first 24 hours to all patients with STEMI who have either an anterior location for their vent, evidence of heart failure, or an ejection fraction less than or equal to 40% unless contraindicated. An ARB can be considered for patients who are intolerant to ACE inhibitors. Ephesus was a trial of patients with ACS who had signs or symptoms of heart failure with a depressed ejection fraction and compared eplerenone to placebo and demonstrated a 15% reduction in the primary endpoint, all-cause mortality. The guidelines therefore support the use of an aldosterone antagonist to patients with STEMI who are already receiving an ACE inhibitor and beta blocker and who have an EF less than or equal to 40% and either symptomatic heart failure or diabetes. I will not be covering in depth the data to support the use of statin therapies, as this will be covered in other sections, but the use of high-intensity statin therapy should be initiated or continued in all patients with ST elevation MI who have no contraindications to its use. Secondary prevention strategies are recommended to be discussed in depth with your patients. For patients who are smokers, there should be a goal of complete cessation of use of tobacco. For blood pressure control, although the recommendations for what specific number to target remain somewhat controversial, a strategy of approximately less than 130/80 is recommended for most patients. For physical activity, we recommend at least 30 minutes of activity 3 to 4 days per week, ideally daily. Diabetes management, again, another area where the goal A1C has been controversial, but the recommendations support a target of less than 7% for a patient's A1C following an ACS event. Weight management should also be discussed with patients to make sure that they are following a healthy diet and maintaining a healthy lifestyle. So with that, I'll transition to the audience response questions. The first question: immediate transfer to a PCI-capable hospital for primary PCI is the recommended triage strategy for patients with ST elevation MI who initially arrive at or are transported to a non-PCI-capable hospital with an FMC to device time system goal of how long? Less than 60 minutes, less than 90 minutes, less than 120 minutes, or less than 180 minutes? The correct answer is C, less than 120 minutes. The rationale is that the benefits of primary PCI appear to outweigh early reperfusion by fibrinolysis when the anticipated transfer time is less than 120 minutes. In instances where the delay is anticipated to be longer than 120 minutes, fibrinolysis at the current hospital should be considered in appropriate patients. Second question: for a patient with ST elevation MI undergoing PCI, which agent is contraindicated as monotherapy? A, unfractionated heparin, B, enoxaparin, C, bivalirudin, D, fondaparinux. The correct answer is D, fondaparinux. All other agents listed are considered appropriate anticoagulant support for PCI. Fondaparinux was associated with higher rates of catheter thrombosis and OASIS 6, and therefore is not suitable as monotherapy to support PCI.